a lot of this is sort of at its heart very scientific. And I don't want to talk too much about that because generally, even when I'm interested in a scientific topic at a panel or talk, I tend to fall asleep in the audience as well. So I won't take it as a personal offense if anybody starts nodding off. But anyway, so let's talk about some basic stuff related to chronic sinusitis. So we all know this. But what we may not fully appreciate beyond the obvious is that it's a very heterogeneous disease. Almost 13% of Americans have this at one time or another. There are about 400,000 surgeries per year, and there's an aggregate medical direct and indirect cost anywhere in the neighborhood of $22 to $32 billion. This slide I've sort of stolen or adapted, I should say, academically from Richard Harvey, simply because I like the slide so much. And he divides it into different eras there. So there's the pre-1980s era where we thought of chronic sinusitis as this problem of chronic infection and obstruction of the sinuses. And then we began to evolve over time where we noted, well, some cases are infection and obstruction, whereas some cases are due to inflammation. And then nowadays we're starting to think more and more that inflammation is the underlying driving factor in most cases of chronic rhinosinusitis. And some of the philosophies that are ingrained began way back in the 70s with Walter Messerklinger, and he was a true pioneer in understanding the anatomy and physiology of the sinuses, but it led to sort of his disciples, David Kennedy and Heinz Stamberger, talking about the osteomeatal complex and how obstruction of the osteomeatal complex was responsible for downstream sinus disease. And I remember talking to Dr. Kennedy about this over a decade ago during one of his presentations, and he was honing in more and more on this subset. This is one of his original slides from 1985. But he started talking more and more about how persistent localized inflammation was becoming more and more of an issue for patients with chronic sinusitis. So even in his schematic of what caused chronic sinusitis, he was focusing less on these other things and more on the persistent inflammation. So where we've been with chronic sinusitis is we think about, and I gave this talk earlier on anatomy about clefts and furrows and recesses and impairment of drainage and mucociliary clearance, and we talk about ventilation of the sinuses, but what we really don't talk enough about is how inflammation weighs in the significance of all these other anatomic features. So let's, if we look at a patient here, we see somebody who's got some a mucosal gland hypertrophy, some submucosal edema. We've got some thick mucus coming out of the middle meatus here, and we think we have an idea about what's going on with this patient. And then we see these two patients, and they've got polyps, which are certainly things that the prior patient didn't have, and maybe there are some subtle differences. This one's got some metaplasia in patient A, and patient B looks a little bit more translucent in their polyposis. So they're both polyp patients, but maybe they're a little bit different. And then there's this guy who has polyps expanding his nasal cavity and sticking out of his nose, and we think, wow, that's got to be a different disease process here than the other three patients. Or how about this? We've got this nasal endoscopy here where we look in the middle meatus and we see this sort of very hyperplastic and sticky mucosa. Is this patient any different from this patient here where I'm digging into the maxillary sinus and I'm getting out all this thick eosinophilic or allergic mucin, and like we said earlier, you got to show the mucus coming out of the nose, but is this patient any different from the other ones that we saw before? So what are we doing with these patients? So we look at a CAT scan like this, and we see mucosal disease in the ethmoids. We see it in the maxillary sinus, maybe some osteomeatal complex obstruction here. We've got some sphenoid stuff. There's some stuff going on in the frontal. So what are we going to do surgically for this patient? We're going to do maxillary antrostomy, total ethmoidectomy, sphenoidotomy, frontal sinusotomy to cure this patient's disease, right? Here's another patient, a little bit more hyperplastic, maybe some polyps in certain areas. It's a little bit more severe disease. What are we going to do surgically? Maxillary antrostomy, ethmoidectomy, sphenoidotomy, and frontal sinusotomy. How about this guy right here? We saw one of these earlier. What are we going to do with this guy? Maxillary antrostomy, ethmoidectomy, frontal sinusotomy, sphenoidotomy. Are these all different disease processes, or are these all the same, or which ones are identical and which ones are not? So we look at how we treat patients with medical management, and we used to talk about maximal medical therapy. Now we talk about appropriate medical therapy. But if you surveyed the American Rhinologic Society about a decade ago, we're using antibiotics, we're using topical steroids, we're using oral corticosteroids, we're using oral antibiotics. But we're still at this time a little bit perplexed why our maximal medical therapy doesn't result in any long-term benefits for a lot of patients with chronic rhinosinusitis. Well, we're still doing the same surgeries, antrostomies, ethmoidectomies, sphenoidotomies, frontal sinusotomies, and then in the end we get frustrated with the results. So we look at our patients and we look perplexed, why do we have patients with recurrent disease? And if you remember from that Sesame Street skit, one of these things is not like the other. Can you tell me which one? So we look at our patients and we say, well, clearly this patient right here is different from the other three. But if we look at all four of them under the microscope after surgery, they may be a little bit more like this. And then when you look at their inflammatory profiles even further, they may look like this. So whereas before, three of them looked alike, and under the microscope they all looked alike, they all may be very different processes in terms of what's driving that inflammation. So what's the reality? Well, CT and endoscopy allow us to differentiate among what we call phenotypes of chronic sinusitis. They don't allow us to draw conclusions about the inflammatory or the pathologic mechanisms. So that's going to lead to failures in medical management. It may lead to unnecessary surgery, and it's certainly going to result in many cases of recalcitrant CRS. Functional endoscopic sinus surgery is based on mechanics. It's based on clearance of obstruction. It's based on ventilation. But as it's currently deployed, it does not differentiate among inflammatory states, nor does it take it into consideration the degree of inflammation in inflammation. So let's talk about the concepts of phenotypes and endotypes. Phenotypes are what are observable properties in a disease state. They're produced by both extrinsic and intrinsic interactions, and they produce an end result or a common manifestation of a disease. So polyps, for example. So when we see a patient with chronic sinusitis who has polyps, we're talking about a phenotypic presentation. When we see a patient who doesn't have polyps, we're talking about a different type of phenotypic presentation. This patient has polyps, this patient does not. And we used to think, well, that's a different disease process because they both look different. And the problem when we look at this, well, we say 75% of our patients don't have polyps and 25% of our patients do, but there are actually some deeper phenotypic relationships that we touched upon earlier that we need to start looking at. So if you look at patients with nasal polyps, as we talked about earlier, 30 to 65% of those patients have asthma, and that says something about a relationship of inflammation that's going on in the body. Or if you simply look at adults with asthma, 2 to 5% have nasal polyps, but patients with severe asthma, up to 20% of those patients have polyps. If you look at the development of chronic sinusitis over time in terms of its association, we notice that patients who have asthma have a 2.7 times more likely chance of developing recalcitrant sinusitis than those who do not have this problem. So we see our patients are those without polyps, those who are a little bit hyperplastic within the sinuses, sort of that billowy, cloud-like appearance, thickened mucosal membranes, and those that have polyps generated. So if we look a little bit deeper in some of these polyp patients or some of the mucosal studies, we get to see certain ultrastructural changes. We get to see patients who have basement membrane thickening, submucosal edema, increased eosinophils in the submucosa, loss of cilia. But the big question is, why is this occurring in these patients? Why do they manifest these histological findings? So we look at the eosinophil, which we talked about earlier. This plays a big role in many patients with CRS. How does the eosinophil get there? What chemical signals are driving the eosinophil into the tissue? It's important because tissue eosinophilia results in a lot of destruction and a lot of inflammation within the tissue. There are studies that show that if you have tissue eosinophilia, your improvements after endoscopic sinus surgery are less, your improvement in olfaction after surgery is less, you have increased recurrence of polyps, you have decreased control of postnasal drip and secretions, increased relapse if you have AERD, and in terms of use of macrolides, your ability to respond goes down. So this is important. And this leads us to understanding the difference between phenotypes and endotypes. And endotypes refer to those biological pathways which explain our phenotypes, or those observable properties. They are defined by cellular changes and molecular markers. These are the chemicals that are driving in specific inflammatory cells into the tissue that are causing what we see in sinusitis. And a lot of us are familiar with Th1 or type 1 pathways and Th2 type pathways. And we can deduce a role for these in chronic sinusitis because we see the associations with other diseases in which the understanding of endotyping is a little bit more clear. For example, asthma and atopic disease. We see that relationship in a lot of patients with CRS. We see the development of late onset asthma in certain patients with CRS versus those who develop childhood or early onset asthma. The propensity for medical failures, the propensity for recurrent surgery. Why do some patients with CRS, when given the same medical therapy and surgical therapy, why do some get better? It's probably the surgeon's fault. They just didn't do good surgery. Well, what if you did a bang-up job? Why did that patient recur afterwards? That was your medical therapy. Well, we put them all on steroid rinses and steroids. Why did they fail? Well, there's something deeper in there other than simply bad decision-making that can be responsible for this. So we know that in a lot of patients there is a preponderance of type 2, or that's that eosinophilic inflammation in CRS. That's going to be very important to understand in terms of what's causing CRS and why we're getting medical and surgical failures. Why is that important? Well, not to get into deeply about innate lymphoid cells and T cells, but these cells release chemicals and attract other cells that disrupt the mucosal integrity, which will allow viruses and proteases and bacteria and fungi to get into the mucosa. It causes hyperplasia of the glands. It interferes with macrophage function. You get increased IgE formation within the tissue. Complement is deposited. You get fibrin cross-linking, which results in polyp bridging. And you get this sort of dizzying array of a wide complex of inflammatory markers and cellular cascades that contribute to what we see in the end as a large phenotype. So we see this, but in reality, this is going on under the tissue. And we have to be able to understand this in order to treat this. When you take out a neck mass in somebody and you have a pathology report that says cancer, how helpful is that to you? What type of cancer is it? Is this lymphoma? Am I going to treat this with chemotherapy? Do I need radiation because it's squamous cell? Is it HPV positive? These are things we think about in other diseases, but we've sort of neglected or thought maybe didn't really exist in CRS until more recent. So we have this sort of phenotypic, endotypic breakdown that I'd like to kind of share with you here, where we talk about chronic sinusitis as our umbrella term. We say that frequently. And then we break it down into those with polyps and those without polyps But each of these phenotypic groups has different endotypes, different inflammatory profiles. And Klaus Bacher and others have done a lot of work over this, and this is a very busy pie chart graph right here. But this is just showing patient populations across the world in the distribution of their inflammatory, their cytokine profiles. And you can see that they're not identical. So some patients have a lot more IL-5 positive disease than, for example, over here, where there's a preponderance of different types of cytokines. So when we talk about use of biologics that target IL-5, we might not have great success in patient population E, where we might have great success in patient population B. So I'm going to spend a little bit of my remaining time talking about some of the studies and experiences we've had at Northwestern about endotyping. And we've published a lot of stuff about endotypes specifically, but we're trying to get into the realm of using phenotypes to predict endotypes. Because simply, we don't see patients this way. We don't see them as a 37-year-old type 3, type 4, or sorry, type 1, type 3 inflammation with X, Y, and Z, or et cetera. We simply see patients who have mucosal thickening and polyps and discharge, and they have a host of complaints, and we need to figure out how to treat these patients. So this is sort of explained by one could think, well, you've got polyps, you've got asthma, the patient's had 4 surgeries, they've got to have type 2 inflammation. It just makes sense to kind of conclude that and say that, but really there's not a lot of data that has rigorously tested and made that relationship. So we think we know what we're doing, but there's not a lot of data to support what we're doing. So over time, over the past decade or so, we've had an increased number of patients recruited each year, and you can see our sort of phenotypic breakdown right here of our patient accumulation. And to assess for different types of inflammation, we're looking at interferon gamma expression in protein levels. We're looking at ECP levels and charcolating crystal, mRNA. We're looking at IL-17 expression, and we're using a pretty high cutoff so we can kind of capture as many people as possible in this sort of assessment. And here's sort of what we found. So if you just look at patients with polyps, you can see the majority of these patients have type 2 inflammation. But there are patients who have type 1 inflammation. There are patients who have a combination of type 1 and type 2 inflammation. There are patients with type 2 and type 3 inflammation there. But look at this white little slice right here. There are patients with polyps where we can't really find inflammatory markers. We're not seeing those biomarkers. Where are the eosinophils? Where's the IL-5? Where is the interferon gamma in this patient? We're not seeing it. It's untypable in some of these patients. Well, let's look at our patients without polyps. It's much more heterogeneous. But surprisingly, look at this. So when we're thinking of patients without polyps, well, they're probably not going to be type 2 inflammation, but lo and behold, about 30 to 40% of them actually are type 2 inflammation. And this is important because we begin to see this breakdown of patients in terms of whether they have type 2 inflammation. And that's important because typically we use steroids in a lot of our patients who have type 2 inflammation. But wait, we have patients with polyps who have supposedly type 2 inflammation, which are not responding to our corticosteroids. Why aren't they responding? Yet we have some patients who don't have polyps who respond beautifully to steroids. Why is that happening? And I think that's because we really need to break down and try to look at things. So some of our data, and this is another busy chart here, but I want you to focus on what's in red here and what I've circled here. These are all patients with CRS, type 2 endotype. They're going to have more polyps. They're going to have more asthma. They're going to have more rhinorrhea. They're going to have more smell loss, cough, pus, and allergic mucin. But look at our type 1 endotypes and our type 3 endotypes. Look at this. Right here, this was highly significant. More women or females had type 1 endotype than any of the other endotypes that were there. And in terms of pus, we saw this much more frequently in patients with type 3 inflammatory profiles. If you look simply at our without polyp population, again, In terms of the presence versus absence, much more likely to occur type 1 inflammation in females. Pus was more likely to occur in type 1, but much more likely to occur in type 3 inflammation. And again, interestingly, not surprising for smell loss, but look at this, headache and migraine, much more common in patients with type 2 inflammation. Again, with our polyp patients here, again, look at this, headache and migraine. This was a complete surprise to us. So when we tend to poo-poo headaches and migraines, but we found it to be much more common in the type 2 endotype. So this is sort of where we're going with this to develop our integrated sort of care pathway. And this is sort of way putting the cart before the horse. But, you know, it would be great if we had sort of like a rapid strep test or something like that for our chronic sinusitis, but we're not there. So we have to look at our endotypes and what kind of phenotypic presentations they may have and sort of come up with a stratification based on biomarkers. And these are some that Klaus Bockert have proposed. I mean, we can do eosinophil counts, IgE levels, and serum, staph enterotoxin, IgE. We can do this through our rhinology lab, but not a regular lab. We can get exhaled nitric oxide through the pulmonary lab, but a lot of these things are not going to be available in most centers, but they are things that sort of help predict our endotypes. So we have this sort of integrated care pathway based on phenotypes. And I can share this with you a little bit later if you want, but it basically takes people through their various phenotypes and endotypes and proposes different treatment pathways. So just for some of my own data right here, if you look at Lund-Mackay scores for patients with various states of disease overall for without polyps and with polyps, and then looking at certain breakdowns, you can see that the more inflamed they are or other reasons, their Lund-Mackay scores go up. If you look at their inflammatory subtypes, they tend to go up as well, looking at these morbidities, tissue eosinophilia, AERD, peripheral eosinophilia. Immunodeficiency seems to have a little bit of a protective effect, perhaps. But quality of life, if you look at their preoperative quality of life, with more inflammation, the higher their disease burden, a little bit lower for immunodeficiency. For their endoscopic scores, more inflammation, worse endoscopic scores. So it becomes a question of how we're going to do our surgery, small, medium, big openings, small, medium, or big openings. And I think, you know, as I talked about earlier, some of the benefits of doing, you know, wide open aggressive surgery are that in those patients with severe disease burden, if you do maximal opening and you do adjuvant therapy with topical steroids or maybe with a biologic, you're going to get, I think, better outcomes for a lot of patients. This is a patient who we did surgery on and has been on benralizumab, and this is the outcome after treatment with benralizumab. These are quality of life surveys of patients over a year. Hard to see down here, but you can get pretty equivalent results based on individualizing treatment. And if you look at the effect of surgery on patients with eosinophilia, these are my patients over a 12-month period. But if you break this down to those who had more conservative surgery versus those who had a little bit more aggressive surgery, I think there's a difference longer out for those who had a little bit more aggressive surgery. Lastly, just a little bit over time here, we did talk about biologics earlier in the lecture. I think that was an excellent overview. But the problem I see with biologics is not so much that they work, is you have similar outcomes with other drugs. We don't fully know what the long-term effects of these are, but I think they're very promising options for patients who have refractory CRS, who, if you know the endotype, these are going to be effective treatments. So omalizumab with a significant reduction in polyps, mepolizumab with significant reduction as well. There are definitely a lot of new studies coming out with dupilumab. So dupilumab is going to be a very interesting thing to look at. But I think the basic thing about endotyping and phenotyping is we know a lot about the disease at this state, but there are certainly things that we don't know. And those are those patients who have untypable disease. We don't know what the highest yield biomarkers are going to be. We don't know how to get people ahead of time and just pull out the data. You know, can we swab somebody or get a sponge or do a lavage in clinic and then decide with that person, listen, it's pointless to do medical therapy. You need to go directly to surgery, or surgery is not going to be helpful. You should just go get a biologic and work with your immunologist. So I would say consider evaluating your patients for asthma, especially if they have polyps. Check for peripheral eosinophilia, check your IgE levels, discuss with your pathologist. Get more than just acute and chronic inflammation on your pathology reports to help you kind of guide your medical therapy. And then lastly, and certainly not least, is find a good allergist and immunologist who can be your partner in treating this chronic condition. Thank you.